Please introduce yourself.
Good morning. My name is Kofi Kichi, someone. I'll be presenting today's ECG and conference. I'll give a background about the case before showing the ECG. So this is the case of a 37-year-old male who was selected randomly to participate in a study that was being conducted back in Ghana, assessing cardiovascular autonomic function among junior doctors with occupational stress. The study protocol was that participants were selected systematically and made to undergo a treadmill exercise stress test to measure chronotropic index and heart rate recovery as measures of autonomic function. And those who were excluded from this study were those who had factors that would predispose them to autonomic dysfunction, such as hypertension, diabetes, psychiatric illness, heart failure, and those with thyroid disease, as well as those on psychotropic drugs, RAS renin-angiotensin aldosterone system blockers, and beta blockers, because all these can affect autonomic function. So this is just to give a background of the selection and how the baseline health status of this participant. So this is the resting ECG prior to commencing the stress test. The focus is on the post-stress one, so I'm not sure if I should pause here. I should just move on. Okay, so this was his resting ECG. And at peak exercise, this was his ECG as well. Now, 30 minutes after peak exercise, this was the ECG that came up. During this time, his heart rate, so this rhythm was sustained for about 3 minutes, and then it self-terminated. And during this time, he was completely asymptomatic. He was hemodynamically stable. He was communicating throughout. And his heart rate was maintained at about 135 to 137 throughout. So I'll pause here for comments on the ECG.
What stage first?
Why did you also story first?
Pardon?
It's supposed to be ECG conference. So you have a question about this ECG, right?
Yes.
We show the ECG first, always.
Okay.
Don't tell us anything about the history.
Okay.
Because we try to exercise you guys' brain.
Okay.
No information. Just the
ECG first.
Okay.
And we discuss as much as we can, gather all the information, and then you show us the new answer.
Okay.
Okay.
During the other people try to find the truth, you can smile.
All right. Thank you.
Okay. Came first.
I think the long-term tachycardia, when I think adenosine extra inject, I see what is the case is more understand.
White florence cardia and heart rate is 160 and maybe I think it's maybe really dissociation. And LBP morphology. I think there is no complex technical with the BPP, morphology, and here is here. And also, yeah. So I think obviously it is rotation and this is and also give us a E6. So I think it is. It could be BT.
Again,
I agree. I think it is also live QRS tachycardia with monomorphic morphology. And I'm not so sure about what these are. So maybe if somebody I'm not so sure. Sorry.
now. And tell us your plan.
So, wide regular, first tachycardia, and we can see the clear P wave, and PR interval and RP interval is not fixed. Change. So, I agree with the AB dissociation, and then with the diagnosis trouble and for the tachycardia. And with the VT, the origin may be RB anterior,
I'll be where?
the anterior.
The NT. Okay, for what? So everybody agree that this is BT, right? Because you saw the AB dissociation. And what is the exceptional case? Even though SVT shows the BA dissociation. If the patient has combined the AB block, high degree AB block, or some other reason, sometimes you can see the AB dissociation, but it is extremely rare, right? So most of people in this room agree 50-50.
I'm not talking about it, it can on this all BP. Get the lead to versus 60. Bottom. So you think this is regular or irregular? Slightly.
Yeah. I also though like to ask that. Yes, you. Why the cars portfolio change a little bit and the amplitude changing?
This is the laser pointer works on that side. So you have it here, amplitude is slightly increased. And suddenly you see this guy here, next to the narrower. And then after that, you got one-to-one relationship.
So
Sorry.
So you need to explain this, why this is different than this. Okay? Also, this one is slightly irregular. You look carefully. So probably ECG, unfortunately, show one-to-one relationship. Okay? But you can see clear cut keyword. Okay? So now I'll tell you that much. Now you think again. What do you think about this? Like the back, that's what she's trying to point here.
another issue is this is not a standard probability.
Right.
Treadmill exercise.
Yes.
During exercise, patients move. Sometimes there's a fluctuation.
So is there any QRS morphology evidence? This is a DP. Do you find any criteria for left bundle branch block PT here? That's, I think, we need to ask first yourself. What are the criteria for left bundle branch of PT? You forgot? Forgot the criteria, any criteria you guys use? Anything fit in there? No, it doesn't.
based on QRS morphology.
Yeah.
I'm not sure. This BC.
Yeah.
Because
Now if you had a transient, let's say, junctional with the bundle aberrancy, okay, and you have the transient AD dissociation, which is a case of a heart block can happen. But that I don't know when they started, but I think it to be diagnostic sure. If you're doing treadmill, you would attach the narrow complex changing to the wider complex. That would give you the best answer right away, right? So your question that you're going to ask when you go to the conference, senior guy call you in front, ask you to, hey, can you read the ECG? Then you can always ask it, can I see the transition between narrow to the wide? Okay? That's exactly what you're going to do in your clinic from this publication. Is there any documentation of a transition from the narrow to the wide to the narrow? That will give you more diagnostic than what we're looking at. Okay? But we can speculate. So that's the important part of your exercise that you're going to do in your career. All right? So what are the possibilities now? This is all agreed this is a VT.
So if I have a caliper,
Yeah,
I would like to measure PT track. And the whether it has to the RR or PT is all the shorter than PP to shorter than RR.
also, especially you have to mark the retrograde here to figure out. For example, this car is wider than this guy. This guy is slightly wider than this guy. You see the variation here. And then this is narrowest. Oh. So the question is that is there a P wave superimposing to the QRS to make it look wider, or QRS itself is wide? But based on what I see here, most likely this is a P wave, I think. This is the guy. But if that's the case, your P wave morphology changes here to here. So this. Now I'm adding your thinking now a little bit more. I'm not telling you the answer, but I'm just asking you to think. Why the P wave would change?
Combine their arrhythmia. I'm not sure QRS with this is changing, but if it is really
Small, very slight,
Yeah.
I think it changed. Imagine.
strange, that could be the
Yeah, especially
Vision B.
this here. Look at this guy here. Here, here. I think it's slightly different. One maybe 40 milliseconds, something different. I think measure would be good to measure.
then it favors fusion beat and BT. It is really narrower than the one.
So it is something that you have to discuss. And what type of BT can do this? What about what are the tachycardia that looks like it is narrowish like that? For example, one of them would be conduction system BT, like a bundle branch reentrant BT, so on. We do a 1-to-1 DA conduction. Okay, that would be differential diagnosis here. So we are discussing that each. Maybe there was a transient during the DT, there was a transient AV dissociation here, and then DA conduction regain. You have a 1-to-1 DA conduction, which is that may explain why the P wave is different. Okay. Then if you look at the lead one, especially up there, he would have got a, which looks like a negative, it looks like a positive. Before was positive when he was a peak exercise. And this is a notch now as well. Anything else you want to add?
Oh, don't that one. Sorry. Every BT from you favor BT. Are you sure?
More likely. But if it's a BT, it's a very slow BT, right? Got a guy exercising, peak, 30-second peak exercise. So the question is, is it truly significant pathologic BT, or this is just going to be idiopathic axial ventricular rhythm because you exercise hard that when reach the heart rate 130. So this is kind of a autozone because the criteria of the AIVR is on up to 110. Some people consider 115, but they just got exercising for 30 seconds. Then what is the mechanism of AIVR? Automaticity or reentry? AIVR. Actually, ventricular rhythm. What is the mechanism? You guys have read the textbook. What did that tell you? You see that in reperfusion arrhythmia, many other arrhythmias, right? It is automatic trigger arrhythmia, mostly calcium related. Okay. So which is it possible? This guy was start treadmill exercising slowly, going up, and then that's what he saw. Anything else we want to add? Anything about the unusual axis of this patient? What do you think? Lap bundle axis plane is normal. Only AVR is negative, right? So whether this, if this was VT, where's it coming from?
Yeah.
Maybe until
Right, interseptum.
Why do you present here?
because in here read is positive and
But the transition RAV is late. B4, B5. And then lead to, AVR had a Q initial on this slide. Then lead one is a positive, all positive.
This is very similar to the yesterday case. Don't you think so? Where did you play? Yeah. So, but if lead one positive, it is more posture side, close to the aortic root, right? Review the yesterday case. Okay. Even though that patient is a little different. His ECG is a little different.
It's B1 is not actually negative. There's a small heart rate, but very small. Okay. That's why it's not truly anterior. In transit is a bit late, then a little bit lower. And then if you go back to the sinus rhythm ECG, okay. There's an axis. Doesn't look like a sinus rhythm. Your VT doesn't look like a sinus rhythm. Pretty close. See that? Go back now, VT. That means gotta be coming close to each bundle, right? So that makes even a rise of a ratio here now. This is coming from automaticity around the common bundle conduction system somewhere, which make a more questionable whether it's AIVR. Okay.
I would like to make the fellows more confused.
Yes.
Let's go back to the sinus rhythm. Even though Dr. Huang mentioned about the potential atrial arrhythmia, sinus rhythm, how's the PWAV sinus rhythm? B1, B negative PWAV, B23.
So slightly RS B1. B1 you have a slight RS, and then biphasic in the region B2. Yeah. But 2, 3 be positive, right?
Right.
2, 3 be positive. So do you have a tracing of the transition of the narrow to the wide?
Yes.
Okay, we'll take a look.
So this
Yeah,
was
there
a
we go.
whole time monitor
Okay.
that was
Wow.
connected.
What do you think?
Okay.
And there's another one of the termination as well.
So Well, let them enjoy this ECG now. Now, what's your diagnosis?
We'll take first. Okay, let's start from Junyoung. Clockwise rotation.
I think he colored that first to be purposely different color. Did you do that?
No, that's so it was a Holter recording. It was a Holter recording, and that's how it codes it.
Okay.
So I didn't
This is
change.
Holter, not treadmill.
No, so a Holter was connected during the treadmill. So both were on.
Anyway,
So then this is how it's coded.
I'm just pointing out now, why the different color? I think a halter is smarter than us. Just okay, right here. Now this AI is powerful now.
Junyoung. No comment. Karen? And which one is Peter?
Here. Here, here we see T, QRS, T, and then here. Not so clear between. Not so sure.
The coupling the word hero, right? First morpho is same. What does it mean? Kyo?
I think it's sinus peak and PAC and
AC,
sinus peak, PAC, PBC
PBC, and BT.
and PT.
Okay. So why do you think the PAC induce BT? Why do you think the white curse rhythm is BT based on the ECG? I tried to make you confused.
So look at that top lead, QRS duration. Go to the all the way to the left. Keep going to the right. What happened to QRS? They vary with.
Yes.
Why vary? That's a question he's asking. Why is it vary? That's you didn't know. Because what? Intermittent capture from sinus fusion. Okay. So during the VT, you have a VA dissociation here. Occasionally, P wave come through the exact critical period where the AV node is open, conduct the conduction system, capture, and the VT going on. Then you will have that narrow looking. So very before that narrow complex, there's a peak T wave, end of it, pointed. Point to come to the right, keep coming. No, keep coming, keep coming, keep coming, keep coming, keep coming. Next one. Yeah, that narrow one before that. The P wave right there and the end of the T. Yes, that conduct capture the QRS part of it. TR is a little longer, but that's what the second one also probably have a less degree of fusion, but capture two. So there's a two fusion, three actually fusion, 1 to 3. That's why QRS become changed a little bit, morphology, okay? Because your QRS morphology changes from first 3B to that one. Yeah, that one different than the other. And the QRS has a notching. You see that? That is the what's the explanation most likely you're looking for. But other lead you can less appreciate that. But I think that lead you can see that. So why the PAC trigger VT? That's what Dr. Park was asking. The PAC is what? Coming from where? Before that narrow complex, there's a P wave right in front of it. TI is shorter. Reversed. Agree? Before the sinus, P was positive. Following that was negative P, short PR. That sometimes we call junction rhythm, right? Because EKG corrected junction rhythm is the key to the R relationship less than 100 milliseconds. We classify the junction rhythm, especially the inverted T wave. That's all the textbook teaching is. And then suddenly become next following wider complex. Is that possible? Then I think the wider complex may have a retrograde P actually. Yeah, that notch.
So now this ECG shows that we can have very important clue of the tachycardia ECG at the beginning of tachycardia. And if you have the termination episode,
Show us the termination.
This is the examination.
There we go. So what happened here?
come on, see your turn. No comment except for termination. Okay. 성현?
Okay, 2 more minutes, you guys comment. We gotta go to the case conference. So the last complex has a P, any P following? The same P that you saw? Last one doesn't have P. It's like a sinus P. Okay. Because if you look at the previous QRS complex, there's a end of the QRS, there's a notching downstream. No, little not, yeah, that one. Don't have that one in there. So sinus capture beat, conduct to the node, terminate tachycardia. So what happened? This can happen in re-entry tachycardia. You can do this. Then you override the re-entry tachycardia, sinus conduction, terminate tachycardia. That's an asking you. Before did that because they had a fusion.
I think it's almost time to wrap up.
So it probably is automatic tachycardia. Okay, competitive automatic tachycardia between sinus and AIVR. Okay, go on. Finish up.
So his echocardiogram was normal, but he wasn't able to follow up with the cardiac MRI to assess if there were other structural issues. Further history showed that in the past he had had episodes of palpitations exceeding physical activity whenever he went to the gym, but after stopping the gym in 2 or so years, he hadn't had any episodes. And since this, 2 years down, this was done 2 years ago. Since this, he hasn't had any other episodes. He's going about his life normally. So that's essentially, he's not on any medications. He's fine otherwise.
So what do you do for him?
Following this, he was asked to start a beta blocker. He took it for about a month and said he wasn't going to continue because he felt fine. So he hasn't been on any medication since then. And he's been
You should
fine.
operate this patient after you're coming.
I think it's gonna be close to your conduction system, so don't bother. Okay, it's not a life-threatening problem. Risk may be higher. Obviously, maybe Dr. Park can update it, but I'm not sure. Young guys also play it.
Okay, it's time to
Okay.
move to the information.
Thank you.
Right.
Thank you.